I think we also have some really nice follow-up now for 9ER presented. Sort of now, we're starting to longer term follow-up for the IO TKI. So 9ER was Cabozantinib. Rana, you want to talk a little about what we saw there?
So I think we are continuing to see a separation of the curves over time, and the delta between the curves right around 10% separation. So I think that's really exciting to see that. But I think, we're all looking for durability. That's the big elephant of the room: are the IO TKI regimens durable or not? I think over time the curves still continue to decline and decline and decline. There isn't necessarily a plateau, though at least with 9ER, what's been nice is we haven't actually seen the curves come together, which has been nice. They've consistently stayed apart with an absolute difference of around 10%. But, there continues to kind of be a decrement. So when we look at duration of response from 9ER, it's right around 20 months or so. So, when we, again, comparing to 214, we're juxtaposing that with the 82. So it's all about durability. But I think IO TKI absolutely has a role in the front line. There are some people that need, when I'm counseling my patients around this, I tell them, do we have to play the short game, or do we have the luxury of playing the long game? And, most patients actually have the luxury of playing the long game. Most patients are not necessarily presenting in, aggressive visceral crisis. But for those people that are, you can't afford for them to not respond. You can't afford for them to grow, I should say. So, I think that's where IO TKIs can play a real role. And I think, we continue to see the solid efficacy data from 9ER. Yeah.
Right. Just when I think about cabozantinib, I think about also the high-risk populations, so liver metastasis, bone metastasis. Bone metastasis is about 20% of population, and so it's usually a poor prognostic category where patients do worse. And what we saw with 9ER update is the PFS hazard ratios are still quite good. It's 0.4, 0.5. And so I think that's really good to offer for patients. Cabozantinib, when I first learned about cabozantinib as a fellow in 2011, was a prostate cancer drug. And, currently is being studied, still not FDA approved as a prostate cancer drug. So it does have really good radiographic bone responses in both disease types.
Mm-hmm. Yeah. It's also encouraging with the 9ER data just to continue to see the quality of life data really bears out in I would say, a favorable way for patients. And, again, we saw at the ASCO annual meeting a few years ago, through CheckMate 214, just how clearly quality of life is itself a biomarker. And that is true here as well. But it's encouraging to see that a regimen that can debulk someone's cancer up front in what, is sort of a really, I try not to use the word aggressive with my patients, proactive way, an intentional way, still is favorable in terms of their overall well-being, because, as one of our colleagues was talking about, when looking at quality of life data, it's important to make sure that we're seeing that their patient's disease response is associated with an acceptable quality of life, and we're not seeing that it's at the expense of an acceptable quality of life. And here, not only is it not, we're seeing it more favorable than sunitinib, and that's great to see, because I think the idea of it not being inferior to sunitinib is great, and it feels like a pretty low benchmark, though, as someone who prescribed sunitinib a fair bit in my training. So I think that's also really encouraging to see that continue to stay consistent in that way.
Yeah, absolutely. I think it's fantastic to see this long-term follow-up for the TKI IOs. And to Alan's point, I mean, we still have benefit. Yes, those with liver mets or bone mets may do worse, but they still get that huge benefit from being proactive with an IO TKI in that space, which I think is critical. I think I do want to sort of maybe talk a lot about favorable risk with Nivo-Ipi. I guess what are your thoughts? You sort of look at by the IMDC risk groups for 9ER now with extended follow-up at the favorable risk versus intermediate poor.
Yeah, no, I mean, I think when you look at the actual numeric medians for the favorable risk, though I know that you're not really supposed to, but it's actually lower in the Nivo Cabo arm compared to sunitinib. I think 52 or 56. I don't know if the numbers are spot on, but it's numerically lower. The hazard ratio is continuing to trend upward. I think we're at 1.1 and change, and so I think as the data continues to evolve over time, and I commend our partners for continuing to follow patients. It's not looking as good in those favorable risk patients.
Yeah, a great irony.
And it's not just this. I think if it was one of them, you would say, okay, but I think we've sort of seen
across
this is a
all.
recurring
it's
theme,
so
right?
consistent. It is interesting. I mean, I think the notion that those patients don't have to be urgently debulked and that the degree of benefit is lower has been a consistent story. Yeah.
Yeah, a lot of these good risk patients, that primary progressive disease rate of 20%, I wouldn't really apply that to that good risk population, because say they don't respond to ipi-nivo, 3 months later, they probably wouldn't have explosive disease right after that. They can go on to IOTK on after that. And the thing about good risk is, sometimes we don't really understand how indolent the cancer is until we've had longer follow-up, right? Maybe these patients don't even need to be treated at all. Maybe they could get SBRT for a couple of lung nodules.
Oh, speaking of that, there's some important trials coming up in that way. There's an ECOG-ACRIN trial called SOAR that's randomizing patients to either stereotactic radiation to their oligometastatic disease versus standard systemic therapy of investigator choice. So another opportunity to support investigator-sponsored research within the NCTN.